You also have to introduce yourself.
Good evening all. I am Dr. Divya Alex, presenting from Giridhar Eye Institute. I am currently pursuing my vitreoretinal fellowship. So, I am presenting my paper on contralateral eyes of polypoidal choroidal vasculopathy, a clinical study. So, polypoidal choroidal vasculopathy, it can present as a sudden hemorrhage at the macula or an exudative maculopathy or as a combination of both with specific SDOCT findings such as a notched PED, a tall peak PED, a thumb-like PED, the presence of a DLS, double layer sign with corresponding branching vascular network on the ICG, or the presence of a hypersinusant nodule in the early frames of ICG. So PCV is highly prevalent in Asian population, and patients with evidence of PCV in one eye may eventually develop similar lesions in the fellow eye. Our study was based on this fact. There are no much documented evidences on the precursor lesions of PCV, and studying the contralateral eyes of the PCV might be one of the greatest measures to investigate the same. So the purpose was to evaluate the clinical findings in contralateral eyes of PCV by multimodal imaging and thereby to investigate any precursor lesions. It was a retrospective observational analysis done in 75 other eyes of unilaterally active PCV in a duration of about 5 years, and two proportion set test was used as a statistical analysis. So all cases of unilaterally active PCV in an age group of more than 40 years was included in the study, and any concurrent retinal diseases and any history of intraocular surgeries other than uncomplicated cataract surgeries were excluded. So all the specific findings from fundus photograph and SDOCT, as explained earlier, were noted, and from the ICG the presence of polyp, pulsatility, branching vascular network, choroidal hyperpermeability and late geographic hypersinusance was noted, and disease activity was defined as the presence of subretinal fluid or intraretinal fluid in the unaffected eye during the follow-up period. So the mean age of the patients who participated in the study was about 64.4 years, and there was a female predilection in a sex ratio of 3:2, and the best corrected visual acuity in the logMAR was 0.7, that means 6/9 or better. So 18 patients of this eye had pigment epithelial detachment, 24 had ellipsoid zone disruption, 6 eyes had double layer sign, and 60 eyes had pachyvessels. So out of these 18 eyes with pigment epithelial detachment, 9 eyes had flat irregular pigment epithelial detachment, which we defined as the flat separation of the pigment epithelial detachment from the Bruch's membrane, and 5 eyes had serous detachment and 4 had drusenoid detachment. So the flat irregular pigment epithelial detachment was found to be increasing in length in the follow-up scans taken. Interestingly, out of these 9 cases, 8 cases developed disease activity within a mean time of 15 months. So showing some case examples, the flat irregular pigment epithelial detachment on a due course of follow-up of 17 months, there was an expansion of 604 microns with the gradual development of SRF. This is another case with a short follow-up of 8 months, the PED with an expansion of 213 microns with the development of SRF. So all of these patients had shown expansion of the flat irregular pigment epithelial detachment. The maximum patient showed an expansion between 400 to 500 microns. We also noted the presence of pachyvessels, which can be defined as larger choroidal vessel compressing the choriocapillaries. All the patients which had disease activity had pachyvessels, but being to the pachychoroid spectrum, 51 eyes which had no disease activity also had pachyvessels. But in enhanced depth imaging, the choroidal thickness was 392 microns, which was much more than the normal population. So 4 eyes had the presence of polyp, 5 eyes had a branching vascular network, and 3 had a combination of both. So this is another case example. On a follow-up of 14 months, the flat irregular pigment epithelial detachment showed an expansion of 787 microns, and the follow-up ICG showing the presence of polyp. So this study included the uninvolved treatment naive other eyes of PCV. The bilateral PCV has been reported in 20% of the cases. Our study could find in 14% of the other eyes. Wu Kang et al. Have suggested that drusen-like deposits with ellipsoid zone disruption above that could be an early preclinical markers of PCV. Our study could find the same finding but could not find a significant p-value for the same. But there was a significant positive correlation between the presence of a flat irregular pigment epithelial detachment and its lateral expansion with the disease progression in the unaffected eye. It also showed a positive correlation with the ICG findings like polyps, branching vascular network, late geographical hypersenescence, which are already non-specific features of PCV. The earliest time period in which the disease activity found was 6 months, and all the patients had a pretty good vision of 6/9 or better at the time of finding out the disease activity. So earlier we find out the lesion, the better would be the disease prognosis. The main limitation was its minimal follow-up of 1 year and a retrospective nature. So this study emphasizes the importance of multimodal imaging in PCV, and the flat irregular pigment epithelial detachment with its characteristic property of elongation may be considered as a precursor lesion for PCV. It may be also considered as a novel OCT biomarker for the disease activity in PCV. Thank you.
No, that's a very good observation in any case, but only thing is, have you done anything having noted that there are precursors in the other eye? So what was your intervention for that? You have seen that there are PCV polyps are there in the other eye in 14% of those patients. So what have you done for them?
We have treated, ma'am, whenever that development of disease activity in the presence of an SRF or IRF was there, we did an ICG FFA to find out that, and if there was considerable BVN or polyp, we treated accordingly. 4 of the patients on the due course needed PDT also. Because of its subfoveal in nature, we did PDT on the due course.
Yeah.
What is the time duration between your treatment on an average of this contralateral eye versus the primary eye?
Sir, the minimum follow-up for the development of SRF in our case was 6 months, and the maximum was 22 months.
You were following up the patient right from the beginning. When the first eye developed the disease itself, you have been following up.
Yeah, this was a retrospective, but from the time which the other eye was developed, we were retrospectively analyzing the patient.
That means your analysis was your follow-up of the patient was prospective, but your study was retrospective.
Yes.
That's